Good afternoon and welcome to HealthSystemCIO.com's All-Star Panel, A CIO's Perspective, Achieving Data Integrity Through Positive Patient Identification, a webinar tweet chat combo from HealthSystemCIO.com sponsored by Imprivata. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the editor-in-chief of HealthSystemCIO.com, and I will be your moderator today. We are having a simultaneous tweet chat hosted by Kate Gamble, our managing editor and director of social media. You can participate in a separate browser or on your phone by using the hashtag HSCIOchat, or you can simply view the tweet chat in the media viewer panel on the right-hand side of your screen. Other WebEx panels we're going to be using today will be the Q&A panel. You can use that to type in a question and send it to me whenever it occurs to you. We'll be posing those later in the program, but again, type them in and send them in as they occur to you. And you could download the deck using the URL on your screen. It's on the bottom of some of our slides, and it has been already sent out in the chat box. Just so you see how we're going to spend our time today, first, we're going to hear from our featured speaker, Aaron Miri, CIO and VP of Government Relations with Imprivata, and then we're going to have our Q&A. So without any further delay, we're going to turn it over to our good friend, Aaron Miri. Aaron, thanks for joining us.
Thanks so much, Anthony. Appreciate that. So today, what we really wanted to talk through was achieving, data integrity through positive patient identification. And one of the concerns and one of the things that I've heard across all of our customers, and even in my prior lives, the hospital CIO and CTO, was how in the world can I figure out who is in my health system, having what done to them, and at what time. And it's amazing that even from everything from a trauma situation where somebody presents that's unconscious, all the way to a newborn, maybe there's triplets or whatnot, it's always an issue in the hospital that's been tried to be remedied old school methods. So paper records or armbands or other means that are not 100% accurate. And so in this day and age, when accuracy matters from a life and death perspective, and now even from a billing and compliance perspective, how can we get to the level of granularity? So today, what I wanted to sort of teach everybody and talk about were some of the things that we're seeing. One, with what is patient misidentification, what are those consequences? We're also going to talk about, positive patient identification options and considerations. And then, what is data integrity? How do I achieve this with positive patient identification? It's not so much that you're able to figure out that patient Aaron is Aaron, but what does that actually mean from a quality and, course of stay? What does that actually mean? So let's talk about the problem. Today, it's been identified that 7 to 10% of patients are misidentified when the medical record is assessed. And, ECRI found out, ECRI found out that 9% of these misidentifications result in an adverse event. This is actually a sentinel event or a near miss doing harm to a patient. In fact, there was an even article here in the Boston Globe in a local paper here that actually detailed and profiled out a horrible outcome that occurred because a patient was simply misidentified. I can tell you that in my prior life, I was in the Dallas-Fort Worth Metroplex, and just due to the socioeconomic status of the people that were there were a number of times that we had a patient present with this very similar last name of a very similar background. And it was a doozy of a time to unravel, is this really the correct patient? Are they borrowing their mother's or their sister's insurance card? What's going on there? So this often led to medical record issues, quality issues, and billing issues ultimately, because the medical record would be invalid because of the wrong patient identified on it. So from a hospital perspective, a number of times what we're seeing from our customers is the customer simply says, oh, this is the cost of doing business. But when they actually tally up what that cost is, it's insurmountable. So why is patient identification so difficult? Well, let's look at this one with Harris Health System. Again, they had 231 patients of Maria Garcia. Again, very similar to what I was mentioning happened in my previous life. They had 2,500 patients named Maria Garcia already in their system. They had 70,000 two or more patients that share the same last and first name and date of birth. And when you extrapolate this out all the way to the top of how many patients they already had in their system, it's crazy. You look at this, and if you look at every single health system in the country, right now, every CIO is facing this challenge, and every CIO is trying to figure out how can I get accurate and better data in so I don't have garbage out. So let's look at some causes. Number one, what happens when you have a duplicate medical record? Well, number one, you're going to have obviously dupes in the EMR. You pull up your Epic or Cerner EMR. How do I select which patient Aaron Miri it is? Now, my name's unique, so it may be a little easier to figure out. But for the previous one with Ms. Garcia, how would you figure that out? And then number two is what we call overlays. And overlays are where I'm inadvertently in somebody else's medical record, or I've merged the records together, and I now have incorrect data in that medical record. You can imagine the potential adverse consequences that could occur from that. And then, of course, another cause of this is identity theft and insurance fraud. Again, the example I gave you earlier where, it's commonplace, relatively commonplace, that you have people trying to present themselves as somebody else. So if you look at what AHIMA found out, they reported that the duplicate health record average is 8 to 12% in all EMRs, and that 40% of all the records are missing or have inaccurate data in one or more fields. And I can tell you from previous life, and for those of you listening that are health IT professionals, you know that not one EMR is the same as the other. And sometimes fields are mandatory, sometimes they're not. And a lot of the times the key conditions and the key identifiers here are not mandatory. It also depends on your state and your local region. So if you look at that, and you have some health systems that span multiple states, even countries, this problem exists at a very large rate. Ponemon Institute conducted a study and looked at this and said there's a 21.7% increase in patients impacted by medical identity theft since last year's study, and this is 2.3 million lives. So this is of a known factor. Again, so much of this occurs in the course of stay that, we have customers. Even recently, we had a very large customer on the Eastern Seaboard tell us, we had no idea the amount of impact this was from both a quality and a financial estimate. So I would say the Ponemon Institute study here is probably on the low side. I would say it's a lot higher, and I would encourage you to look in your health system and say, hey, how many Maria Garcias do I have in my EMR? Another factoid, the advisory board, it reported in 2013 the average 250-bed hospital lost more than $7 million due to inaccurate or incomplete documentation. That's crazy. That's an insurmountable amount of money. I was a CIO of a hospital about this size, and that was almost my entire budget for the year. So how is it that we're dealing with this and saying this is a simple cost of doing business? Let's look at some other facts. So joint commission statistics are always interesting to me because, of course, that's what you're graded on, and the TJC shows up, and you want to pay attention. So what have they found? They found that several sentinel events could have been correlated back to patient misidentification. Over 1,200 were a wrong site, 475 medication errors, 41 radiation overdose, 137 transfusion errors. Infant discharged the wrong family 3. Can you imagine that? Again, these are things that are occurring every single day. I think one of the toughest jobs of being a health IT professional, whether it's a CIO or whatnot in a hospital, is trying to put to words, why is it important to me? Why should I care more about this than, say, meaningful use stage 3 or whatever it is, the latest thing facing you? And it's quite simple. This is about real-world effect and also the bottom line. And so for all of us that were charged to do more with less and to make sure that you have good quality outcomes, figuring out who your patients are is right up there at the very top of your list. So some other stats, and I'm a big on data person, so I think it's good for all of you to learn and understand this. Some of the medical errors, if you dive into this, 27% of all radiation errors were found from patient misidentification. 29% of medication errors are because of misidentification. I mean, how many times do you know an order is placed multiple times in your EMR because the wrong patient was selected or somebody's charting under the wrong name? It happens all the time. And again, it's been labeled as, oh, this is the cost of doing business, but it doesn't have to be. It doesn't have to be if you have the right technology and the right processes in place to mitigate this. So what happens with misidentification? Again, we talked about this a little bit, but it's important to stress. One is patient harm. Do no harm. That's number one with everything that you do. You want to make sure you have good quality outcomes. Number two, loss of revenue, which, I had a CFO one time put their arm wrapped around me and said, Aaron, I'm glad the EMR is up, but our financial system's having a problem, and I can't pay our clinicians or keep the doors open, so we can't help our community. So the loss of revenue is huge. Cash is king. And then number three is unhappy patients, which is critical. All of us are trying to figure out how to streamline the patient experience aspect at our hospitals and how to make sure that, we have the best outcome with the best, happiest patients so that when the HCAHPS scores come back, everything is all good. Well, this ties right back to it. If you can't figure out I'm the right person and I was potentially mistreated, I'm not going to be very happy. Something else that's important that you should look into if you're not already. MACRA is making changes has enacted changes for what's going to be placed on the Medicare and Medicaid cards. And this is strictly because today it leverages Social Security number, which, as you all know, I think if you look at the Equifaxes of the world, I think everybody has been breached a couple times over by now. But regardless, having a Social Security number out there is very bad practice. It's very, very antiquated, and it's going to be modernized. So right now, Social Security and HHS and CMS are partnering to place randomized numbers on all the new cards being printed, which in fact will make it a little bit even more difficult for hospitals to figure out who are you. This is a massive undertaking, and I'm sure all of you are looking at this, but you need to be thinking about today, how are you going to do patient reg, and how are you going to validate that this is truly Aaron that has this card in hand? So when is this going to happen? Now. By 2018, every system is supposed to be ready to receive or send the new MBI, and you have 3 years to get ready, actually 2 years to get ready. You start next year. So it's a matter of starting now during that journey to make sure that you realize who is who. All right. This is a graph I want you to look at and pay a little bit of attention to. I've kind of talked about this in a high level, but this is important when you're trying to figure out, especially as a CIO, trying to explain to your CFO or CMO or others, why should I invest in this? Why do we need to look at something like this? And the top left corner is pretty interesting. Number one, it's all about data integrity. It's all about what are we getting, what's the return on value for my IT investments. And as a CIO, I was always justifying why is it I'm spending this amount of money for an EMR? I'm spending this amount of money for a tool. It's the same reason why an operational director would say, I need this amount of money for a new bed or a new tool or a new CAT scan. It's all about those types of things. So how do you give back a return on value? Each of the dimensions that play into patient identification each have their own what's in it for me statement. So from a clinical perspective, it's about patient safety. From patient access, it's about identity fraud and ease and efficiency. From a finance perspective, again, it's revenue. So I would encourage you to look within your four walls and look beyond that to figure out what's important to your hospital system, what's important to you, and how does patient identification really affect you. And as I gave an example earlier, a lot of times hospitals simply haven't looked at this in aggregate to figure out and realize just how big of a drain this is on your system resources. So how can hospitals solve the problem? All right, I think I've belabored the point that this is a problem, so how can you solve it? Number one, clean everything up. Now, sure, you can go hire, dozens and dozens of phenomenal HIM professionals that could whittle through all the records and clean it up, but that's pretty costly. You could use a third party. And sure, that solves the problem point in time with some iterative improvements. But, what are you actually going to do to make sure that you're being proactive about it? Are you going to use EMPI solutions? Oh, they're great, right? You can do matching, you can find heuristics, you can look for commonalities, you can weed it down. But is that good enough? No, because you still dirty data in, dirty data out. So you have to encapsulate everything with some sort of specific identifier, such as a biometric. If you look at the NIST standard for a level of assurance, the highest level of assurance, meaning I know who you really are, I know you're really Aaron, is some type of biometric, whether it's fingerprint, whether it's voice, whether it's facial recognition, whether it's palm vein, whether it's iris. All of those have their pluses and minuses and are appropriate depending on the continuum of care. So from a comprehensive approach, I kind of break it up into three buckets that you need to look at. Number one, clean up your medical records. You've got to clean up your existing data state. There's fantastic companies out there that do this. I use a number of them in my previous life. If you're going through an EMR optimization or an EMR swap out, that's the best time to do this. Number two, as I mentioned to you just a minute ago, biometric identification. You need to be able to identify your patient up front on intake. And I would say you need to have multiple modalities of biometric identification. It's not just good to have palm vein. You got to have palm vein and iris, or you got to have fingerprint and palm vein, or you got to have voice and something else. The reason for such is you're going to have anything walk through your doors at any given time. I tell folks all the time that a hospital is like a shopping mall. You can have anybody show up. That's the beauty of it. But then the downside of it is you have to plan for all of that. And then third but not least, it's all good to have the technology and have a clean level state, but if your processes are broken, your workflow is broken, you're just going to end up right back at square one. So you have to walk through and optimize your workflow. You have to understand at the point of registration, at the point of care, what are we doing? How are we handling it? How are we verifying that when Aaron is moved from a level of care to one thing to another, that we actually know that it's still Aaron? I mean, it's great that you were admitted from the ED to MedSurg, but how do we know that's still Aaron? What's the process there? What are we doing to check that? So a little bit about medical record cleanup and patient matching. Right now, in your EMR, I guarantee you that if you have had an EMR for more than a few weeks, even probably a few days, you have an issue with dirty data. You just do. And it's one of those unspoken, yeah, we know, we just have people merge it, or we have the nursing supervisor go through and merge record. It's a mess. And for those health systems like mine that were celebrating their centennial, right, 100 years plus old, and have so many medical records, it's a problem that's extrapolated out. So you have to be able to assess that and clean that up. And again, there's a number of ways to do it. It doesn't matter which way you go about it. You have to start there and clean up your house. Number two, biometric identification. Some considerations when you think about biometrics. One, what is the level of accuracy for the biometric you're using? Again, I mentioned a few earlier. There's palm vein, there's iris, there's voice, there's fingerprint, there's facial. There's a whole lot of them out there. But the ones that are right for you depend on your circumstance. Are you more ambulatory? Are you acute? I mean, I can't rely on an iris if I'm in the ED because the person may be unconscious. I can't rely on voice because the person may be unconscious. I can scan their palm because the palm vein never changes. Those kinds of assessments you have to go through. Two is permanency. Is this a physical trait that's going to be stable, or is it something that's going to change? Case in point, one of my previous lives was pediatrics. Well, kids grow. So, you know, if anybody's gone through the challenge of taking photos for the medical record, you know that, especially in a ped setting, you're having to take that photo almost every year, if not every 6 months, because that child's growing. Well, is facial recognition going to be solid for a child? Well, Apple says not at the age of 14, not right now. So you've got to look at what biometrics you're putting in place. Number three is applicability. Who can use the technology? You know, are there any limitations there? Are there physical limitations? And then four, adoption. Are there any stigmas? I can tell you that in some states, we have run into the challenge with there being religious concerns. Now, it's not many. It's very, very, you know, very spotty. But it's an appropriate question as to, hey, is this potentially something that's, you know, going against my beliefs? Okay, that's why if you have multimodality as a hospital system, you're able to address their concerns of the patient in a manner they feel comfortable with. So palm vein. So how does palm vein work? Because you know, a lot of you, especially healthcare professionals, probably have seen a vein finder for the nurses and clinicians trying to do a blood draw. It's much in the same way. Amazingly, what we have found and what we are seeing a major adoption with is that your veins in your palm don't change. What you're born with is your pattern. Yeah, your hand grows, but your pattern never changes. So much like a vein finder works to find your vein, the representational image of your palm veins can be scanned and can be accurately scanned every single time, and it's very seamless. It's much like using your iPhone with your thumb. It's the exact same way. You hover over the path, and boom, it reads your palm vein. We're seeing that to be growing in popularity because people sometimes associate a fingerprint or other modalities with law enforcement, and that's not something you want to be in the business of as a hospital system. Iris scanning. Iris scanning works by identifying the patients through a pattern recognition of the iris. This is good for folks that truly are concerned about putting their palm on anything. Potentially they have some sort of immune deficiency, and they want to be very careful with what they touch. Iris is touchless. You look into a little camera. It looks like one of those old school red little photo things that you used to put over your eyes to see the pictures of where you're going. I forget the name of it now. But it's very easy and seamless and scans you very quickly. So what's the best approach for at the end of the day is workflow optimization? One, we've seen patient self-check-in. We're seeing a lot of folks now into industry kiosks at registration. We work personally with a lot of leading ADT systems like Cerner, Epic, McKesson, and Meditech to be part of that workflow up front. Third, at point of care, we have one customer of ours that is doing this for oncology. You can imagine those drugs are very, very life-saving and critical, and if they're administered to the wrong person can have very adverse consequences. So we're seeing that at the point of care there. And then, of course, revenue capture. What are all of those processes that when you're submitting a claim up to make sure that you truly are coding the right patient on that claim so you don't get something that is through adjudication or now in bad debt because you just didn't do your due diligence. All right, so how does this work with ADT? It's great, Aaron. Today we check and we scan and we make sure that we have your information and that you really are Aaron. Okay, that's great and all, but we have to make sure at the end of the day that I'm not a good fake, and I'm not just pretending to be Aaron. I'm actually Aaron. So how do we work? And this is a lot of the solutions do this. One, we create a biometric enrollment one-to-one link with all the MRNs from multiple clinical systems. So like in my case, I had Epic, I had NextGen, I had Athena Health, and they were all still in use depending on what clinic, what practice, inpatient or outpatient. So for our situation, we'd have to link all those together. Number two, we securely and accurately identify the patients at the point of time on the reg screen. So make sure whatever solution you're looking at, that it embeds itself right into the workflow. The last thing any registrar wants is another click, another place to go to. And then, of course, you've got to validate that it's the correct clinical record. All of that is very, very important. To the degree of it, I want to stress it's all about simplicity, and it's all about making sure that the registrar, the point of care, quick reg in the ED, ambulatory clinic can easily get you in the door without adding too much complexity. So whatever biometric solution you use, whatever you go with, you must do something that is in line with today's workflow and what they're doing today. So understand what your hospital does today. Point of care verification. All right, I already mentioned one with oncology. We've seen other ones for surgery, surgical pause. We've seen some customers of ours take surgical pause to the next level. And for critical patients, VIP patients, peds, to make sure they scan the patient, not just the armband, but they do a pause to make sure that this is truly Aaron. We didn't get the armband swapped, or we didn't get a medical record completely goofed up and we have the wrong patient there. We've seen it for blood transfusions. Another clinic of ours or another client of ours is doing dialysis. They have such a high volume of patients coming in for dialysis that they want to make sure that the patient is coming in at the appropriate time, is the appropriate patient, and that they're given the appropriate meds. Of course, radiology, laboratory, and nephrology. All those are pretty self-explanatory. It's all about making sure it's right place, right time. Biometric identification really helps streamline the entire adoption cycle. And from a level of, at the end of the day, you need to make sure that your adoption is successful with reporting analytics. And so I stress to all of you that even as you go through this entire process of each life cycle, each stage of how to identify and positive patient identification and all these sorts of things, you have to know what you're measuring. You get what you measure. And to the degree of it, to make sure that, we didn't just have a good outcome, but in our totality, in all of our patients and everything that we're doing, that we're actually getting that return on value we were promised up front. So let's look at a few success studies, and these are our customers, and I think there's customers, across the board that are doing this successfully, but I'm going to put a couple of them that I think are valid, and I'm all about data. Again, I don't like to just talk about things. I want to show you examples. Carolina's Health System, gigantic health system located in South Carolina, led by fantastic leadership there. They reduced a duplicate medical record to 0.01%, down from 5%. They reduced their check-in times by 75%. They had a major issue with insurance card theft. And of course, they had patient safety and satisfactions that were improved across the board. Carolina's healthcare system is 36 hospitals, 1,000 clinics, 4 million plus patient census, multiple HIS systems. I mean, to get it down to a 0.01 dupe issue is amazing. I can't imagine the level of efficiency that they picked up with their staff. And imagine how many near misses that they probably prevented because of this. They had 125 information systems feeding patient data into their EMR. The achievement they would get with 0.01 is 80 times better than that of a national average. That's amazing. And all they did was look at the issue and say, we're going to solve this with multiple layers and address this in totality. Another example, Scripps Health. They really had a challenge. California is a phenomenal state, but has very unique challenges too, and they wanted to get in front of this. So number one, they wanted a biometric method that was offered that was non-invasive. They went with a solution that they had that was not impacted by lacerations or dirt. They wanted something that was low maintenance. They wanted a streamlined registration. They wanted to interface with multiple EHRs. And they wanted something that was useful even if the patient was unconscious. They achieved they had a medical record error rate that was decreased by over 30% because of flyers and all sorts of identity card theft and people coming across the border that were pretending to be somebody else. And so what they ended up with at the end of the day, like I said, they reduced their medical record error rate by 30%. They discouraged all those frequent flyers. They eliminated any real need for identification unless you're presenting for the very first time, and they were able to speed up the registration process. So for them, it was a tremendous success. And again, they looked at their challenge and said, hey, we have this issue of people coming across and we're not able to know who they are. And they went after it. Each of you as healthcare professionals have your own challenges. So you have to identify what is that value prop for me. I stress that, at the end of the day, no one health system is like the other, and no one health system has the same patient identification problem as the other. As a CIO, that's often difficult to convey to the CFO, CEO, and others. But each of us, signed up for the job of making life better for our patients and making sure that at the end of the day that we're able to provide a system and systems that provide vibrant outcomes from a quality clinical perspective as well as a financial perspective. I encourage all of you to look at positive patient identification in aggregate, tackle it in those chunks I mentioned to you, and I'll tell you, there's not many IT projects per se that you could do that have a huge ROI like this. You should look at it. Thank you.
All right, very good, Aaron. Thank you for that very interesting and informative presentation. We have time now for some Q&A. So we would encourage people to go ahead and send your questions into the Q&A box and leave the default set to all panelists. Aaron, let me start out by asking you, as a former CIO, you talked about your health system and issues that it had like every other health system. Is this something that it's hard to admit one has a problem with? Sort of you have to admit you have a problem to get better?
Great question. I think it's a problem to identify the source of the pain. And that's because by the time in today's methodology and today's 1.0 methodology, by the time you realize that you've had an adverse outcome because of patient misidentification, usually it's farther down the stream than just registration, and so you have to peel back the onion and figure out where did we go wrong. So it's not necessarily having a problem admitting it. I think hospitals are very open to being transparent. They often don't realize that, oh, this is because I didn't on intake select the right patient.
Right. So there's no issue there about sort of avoiding seeing the problem, because in seeing it, we admit that maybe it reflects badly upon us as healthcare IT leaders.
No, I think hospitals are very transparent, and I think, one, they're forced to from a compliance perspective, but number two, truly, and I mean this after over a decade of healthcare IT leadership and longer in healthcare particularly, is that almost every clinical leader I've ever met is in it for the right reasons, and they want patients to get better. So I think if we were able to extrapolate out, and that's why I encourage folks to go through their data, go through their EMR, look at their dupes, they would realize this problem is so rampant that if you bring it up to any CNO or CMO or CQO, they'll say, gosh, get in front of this right now. This is a train waiting to derail if it hasn't already.
Right. Are there manual approaches? We talked about, Imprivata's got a tool. And you talked about sort of, I don't know, the futility or inefficiency of trying to tackle this manually. Can you talk a little bit more about that, how some people may be trying to get their arms around this without making an investment in a tool, but that might not be the best way to go?
Yeah, so I have a lot of respect for HIM professionals. I think their job is one of the hardest jobs in a health system that is behind the scenes as they manually match up records. They look at, usually all these different criteria from full name to address to social security, birth date, all these criteria, and they sort and figure out, okay, what records do we need to merge because it's actually the same patient? What records are incorrect? Maybe somebody was charting under the wrong record. I mean, they have a hero's job. And so some health systems that we're seeing have a small army of HIM professionals that are literally sorting through this on the back end. And I can tell you of one very large health system here in the Massachusetts area that actually has an EMPI solution, and they have a small army of HIM professionals that they have not been able to make more efficient because they haven't put biometrics in, and they want to put biometrics in order to help mitigate that issue. So it's a multi-pronged issue that you can solve by having a small army, as I said, and being very elongated with your medical records cleanup, or you can begin to put technology solutions in and whittle this down to a manageable feat.
Well, a related question just came in from the audience. Are hospitals beginning to increase skill requirements for patient registrars and increase pay in a quest to reduce duplicate medical records?
I would love to say yes, but I think that every hospital is being constrained by razor-thin margins. What we're seeing across this country particularly is that hospitals are trying to figure out how to do more with less versus higher-end people. So where technology can help reduce complexity and reduce the number of physical bodies necessary, you're seeing hospitals willing to invest, knowing the long-term payoff, or even the short-term payoff in this case, is worth it.
Yeah, and so do you think this is an easy sell to make to whatever IT governance program or process you have in your hospital? Whoever the CIO, let's say the CIO is a true believer, whoever they have to make the case to, the board, again, the IT governance process, you gave them a lot of ammunition. Do you think this is a pretty easy sell, or does it need to be articulated in a very specific way to get the point across?
Yeah, so I would stress to everybody, remember the two buckets I sort of mentioned earlier. It's one about patient safety and quality, right? That's always paramount. That's number one. And number two, revenue. And if you look at today's environment, and again, with the capitated markets and with the movement away from fee-for-service and these razor-thin margins that hospitals are operating under, if you are able to positively affect either of those two buckets, in which case identifying your patients hits those right out of the gate, for me, it's a no-brainer to any board to say, hey, I need to invest in a solution to make sure that we're a lot more safer with our patients. And number two, we're able to recoup the money we're literally throwing out the window today saying, oh, it's a cost of doing business.
All right, so let's say the CIO has made the case and they've gotten the funds and they have to go pick a tool. Obviously, Imprivata offers a tool. What would your advice be to your CIO colleagues out there about how to make a selection and pick the right one for them?
Yep. Number one, don't just buy a tool. Make sure that you understand your unique situation for a hospital, what you have going on, where you're registering patients, what's your intake process. What I did in my previous life was I partnered with our financial services teams, of course, our case management, our HIM department, our patient reg department, and I did the whole seek first to understand to figure out what is the problem statement, where are patients coming in from, how are we intersecting with them as a healthcare system, and then I went back to look for tools in the market that did that. Again, not one tool is better than the other. I think I'm personally biased towards things like palm vein because it works every time and it works for unconscious patients, but iris is good, others are good too. So for you, you have to look at and select a tool that's applicable to your environment. Otherwise, you'll fail.
You know, we hear all the time when it comes to EHR selections, it can't be led by IT. Is this the same type of thing where it can't be led by IT? It's got to be led by those departments that you mentioned? And then if so, what is the CIO's role in the process of either selecting or implementing?
So a good CIO knows they're only as good as their partners. And again, I speak the world of the clinical folks that I've worked side by side with today and yesterday. They all want to do the right thing. So as a CIO, it is your charge to partner with them in looking at tools, identifying the problem, and being a trusted ally of the clinical and business staff of the hospital. To the degree of it, no tool, no IT project will ever be successful without willing partners to go along the journey with you. You know, I have been very fortunate to work with hospital CIOs in the past as mentors that were phenomenal at this, that they know how to really rally a coalition of the willing and explain to them the problem in a way that they get it and it becomes their problem. So in this case, because it's a quality issue, it's a patient safety issue, and it's a revenue issue, it affects almost everybody in a hospital setting. So finding champions and co-champions for this project shouldn't be too difficult if you're able to articulate the problem. And the problem is pretty obvious if you just do a little bit of homework.
And it's a fascinating process, right, by which healthcare IT executives and CIOs lead, but in leading, they get others to really take the lead. So they rally, and you use some interesting terminology, they rally, they build the coalition, but not by being out front, by putting those others out front, right?
That's exactly right. As a CIO, you don't want the spotlight. You don't want glory. You want to make sure that at the end of the day, that your partners, your fellow clinicians, your fellow business leaders, that they are able to deal with an issue that's affecting, again, patient care, revenue, whatever it may be, and that you're teeing up the options to make them successful. That you're the greatest enabler as a CIO, and understanding their world and understanding their problems is the most important element of being a CIO.
So we talked a little bit about tool selection. Can you take us through a little bit about implementation and the healthcare IT executive's best role during the implementation process?
Absolutely. So the way we do it with our customers is we take a multi-pronged approach. Number one, there's of course the technical implementation, so making sure that we have native integrations with EMRs, so we're able to work our solutions into their existing processes for registration today. Number two, we have a clinical team that works with the clinical staff of each hospital to make sure that they understand, there's going to be scanning, palm scanning, iris scanning up front, what they're going to be able to validate against. And number three, there's always the project component to it, to making sure that the business sponsors, executive sponsors of the project are kept in the loop of the entire way, top to bottom. The other thing that I appreciate the approach is, especially as a CIO, is what's my kind of anticipated return on investment? What am I looking for? And so for any solutions or anybody you're partnering with, make sure up front you ask, hey, what's my expected return on investment here? What am I looking at being able to save, both financially or deduping medical records? What's my return on value? And so look for vendors and partners that will give you that information up front and say, your mileage may vary slightly, but this is what we've seen from other similar hospitals and customers.
Very good. Most tools, again, we talk about EMRs a lot, have an implementation phase followed by a longer optimization phase. Is it the same go for this particular tool? You get it put in, but then there's a lot of bells and whistles that you could use and you kind of should use, or you're leaving some things sort of on the shelf?
What we found the most interesting is that people and customers, and especially the registrars, will suddenly start optimizing their internal processes based around this. This will solve the intake problem, but then they'll realize, we could put this in for when people change levels of care, or we can put this in the discharge process, or like I had said earlier, for the OR, for the surgical pause and those sorts of things. So what we have found is it's not so much the tool, but all of the positive ways that you can improve the entire course of stay using technology. So we've seen a lot of customers go off to the races with this and start improving all sorts of challenges across the board, not just patient reg.
One other question occurred to me. We talked about making sure you have the right patient so you do the right treatment from a clinical point of view. You also touched on the idea of, and we've heard this before, of patients presenting and intending to commit insurance fraud, maybe just to get care, not trying to put money in their pocket just to get, that doesn't make it right. I'm not trying to say it's right. But let's say somebody coming in and the health system's job is to make sure they have the right patient versus someone coming in trying to commit fraud. Does the hospital need different tools, different approaches to deal with those two scenarios?
Yeah, so putting EMTALA situations aside, right, which are governed by law, if it's truly somebody presenting, the hospital does a really good job of working with the person in need to make sure they get care, whether it's at that facility or a facility with charity care or whatever it may be. I would be hard-pressed to find a hospital system that wants to turn away somebody and says, you know what, too bad, I don't trust you, just deal with it. Again, clinicians and hospital professionals are in it for the right reason. They want to make sure people get care. But to your point, there are different processes for each of those. And there's different, again, local laws, national laws that govern each of those processes. So the technology has to be such that's flexible to adapt to those different processes. And so that's why, again, I'm privy to something like Palmvein, because you can put it in almost any scenario and it works, and others may not be. So again, depends on your local situation, but for the most part, it's all about process.
Yeah, and just as a final question, we've heard that communication is incredibly important to getting these type of biometric things adopted. It makes people comfortable, sets the groundwork, especially with patients. They need some sort of groundwork or explaining, and maybe even staff too. This isn't something you just want to throw out there. This is something you really need to lay the groundwork for and explain away any fears they have about Big Brother type stuff.
I think communication and every technology is important, but to your point, yes. However, let me tell you this. I was talking to a CIO of a very large health system in South Florida who put in Palmvein, who told me, he said, Aaron, our patients coming in, putting their hand on those scanners, actually felt more secure. They felt like, okay, you've got my back, because it's something tactile I'm able to touch and see, and it makes me feel reassured you got my back. And I said, that's a very interesting dynamic I hadn't considered, was that security blanket perspective of a patient going, man, I really need help today. I'm in a bad state, but I can see this hospital's got their act together, and I want to be here. So he turned it into a competitive advantage that they were able to do biometric identification.
Excellent, excellent. Well, that's about all we had time for today. An excellent presentation, an excellent discussion. When you close out your WebEx window, you're going to be taken to a post-event survey. If you could take a moment to answer that, we would appreciate it. For those of you who have the CHIME CHCIO certification, attending our webinars gets you 1 CEU. Please let CHIME know you were here, and if you've asked us to do so, we will. You receive an email when this archive recording of this event has been posted to our YouTube channel. If you would like us to produce a webinar on the topic of your choice, you can contact Nancy Wilcox from our team, and you can go to our website to view our upcoming schedule of events. So with that, I want to thank Aaron Miri, I want to thank Imprivata, and I want to thank all you, our attendees, for frequenting our events. Everybody have a wonderful day. Thank you.